6:30. We'll go ahead and call our meeting to order. Let's go ahead and have a pledge to the flag before we do anything else. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Our first order of business is public comments with respect to the issuance of Lake Health District of tax-exempt bonds in principal amount not to exceed $5,604,250 to finance construction and equipping of an approximately 22,500 square foot long-term care facility and assisted living facility and related improvements, and to pay costs of issuing the bonds. So I'll open to the public, if anyone cares to make some comments or ask questions. Hearing none, I'll go ahead and close that part of our meeting. The next business is we're going to work on our resolutions for the issuance, authorizing the issuance and sale and delivery of Series 2015A revenue bonds, designated an authorized representative, delegating the negotiation and approval of financial documents and related matters. And the second item will be adopting another resolution, 2015-4, authorizing the issue, sale, and delivery of Series 2015B revenue bond, designated an authorized representative, delegating the negotiation and approval of financial documents and related matters. I guess we're asking for a motion?
Do them separately.
Separately? Okay, let's ask for a motion on item one.
Before you do that, do you want to have me, I have Gwen Griffith, attorney from Tom Contorp, available on the phone. We could call if you have any questions about these resolutions. I've sent you out draft copies. If you don't mind, Chuck, I could just say a couple things. One of the things I want to make sure that you understand that all the issues as it relates to these bonds, to the best of our ability, where we stand. If you'd like to have Gwen available, we could get her on the phone.
I pretty much understand this.
Okay. Okay. Gerald?
Yeah.
Judy? Okay. Because we have been, Cheryl, Jim, Gwen and I have been working a lot to try to make sure that we get all the financing information accurate. There are, Gwen has helped us, well, the number of documents that we have, there are 27 documents that we're working through. I think I sent you a list of the documents. I think I sent you as many of the drafts as we could. There are still, Cheryl and Gwen worked out some language on the debt service coverage ratio, meaning that the ratio for any given measurement period of the change in unrestricted net positive net position as defined pursuant to GASB principles, plus interest expense, plus depreciation and amortization, plus unrealized losses or minus in unrealized gains stemming from mark-to-market adjustments on investments, and interest hedging activities, plus any other non-cash expenses less a proportionate amount of $900,000 in annual capital expenditure spending to the sum of the required principal and interest on all indebtedness due to the measurement period. So we added that into the agreement, including the unrestricted net position shall be the total net position reflected on the borrower's balance sheet, reduced only by restricted non-expendable amounts. So that gave us a little bit more flexibility in terms of our borrowing capabilities. So that the covenants aren't quite as restrictive as the bank originally had asked for.
Charlie, I noticed in October 22nd,
date? Is there something magic about that?
Absolutely.
Date?
Once you agree to these resolutions tonight, you're authorizing me to execute the list of documents. And Tony, please jump in if there's anything that I say that isn't accurate. Tony's with Moss Adams, and so if I am not clear on something. So then, once we do that, then we still have some issues with the covenant agreement that we will be resolving. We have a phone call tomorrow with the group, Washington Federal. When we sign the agreements will be signed on October 21st, and October 22nd is the date it will finance, or fund, rather. So all the specific arrangements to which bank, where the monies go, how it gets transferred, will be decided. It will be predetermined, and will be finalized on the 21st, funded on the 22nd. One of the restrictions the bank wanted to make sure that you were aware of is, because we are doing both resolutions and funding both resolutions on the same time, on the 22nd, we have to take out a minimum of $50,000 for the Series B. Series A is for the refinancing component, that's the $13.3 million. The Series B is for the new construction. Because we don't have a finalized contract from the Adroit Construction on exactly the dollar amount when they start all of those components. So the GMP agreement, until we have that, we can't draw any money down out for construction outside of the initial $50,000. And that initial $50,000, they have to draw out some dollars in order for the two agreements to fund on that day. And so that $50,000, we've already had those kind of expenditures that we paid to Pinnacle Architecture and to some of the legal fees that we've incurred, because we're paying for that as we go. So that money will go to reimburse the district for those expenses. But it will not go toward paying Adroit Construction, because they haven't done anything. Okay.
My only question for Jim to answer would be, is there any unusual liability on the board members, or especially the chair? Okay.
I think it's also important to know that this will not have any impact on the tax rate for any of the voters in Lake District, Lake Health District. There will be no increase in any taxes to the members. I'm not sure that was made always clear, but I wanted to make sure that you were all aware of that. Covenants are all pretty close to worked out. Jim and Gwen have been reviewing this. We think we have good agreements. The changes from what I sent out to you, because I sent you drafts, I included the names specifically of which bank the loans are from. So, for example,
And the amounts are
in A, it has the origination amounts, not the current amount that is due. Okay, so those numbers are slightly different than what the actual amount is. That will be determined on the 21st. It means it's projected, done on the 21st and funded on the 22nd.
If there's no questions, I would ask for a motion to adopt resolution number 2015-3.
Also move that we adopt the resolution 2015-3, authorizing the issuance, sale, and delivery of Series 2015A revenue bond, designating an authorized representative, delegating the negotiation and approval of financial documents and related matters.
Second.
Thank you. Those in favor?
Aye.
Aye. The same for 2015-4.
I'll move that we adopt resolution 2015-4, authorizing the issuance, sale, and delivery of Series 2015 B loan bonds, designating an authorized representative, delegating the negotiation and approval of financial documents and related matters.
Second.
Those in favor?
Aye.
Aye. Thank you very much. Okay, we'll move on to regular business. I'll open the floor to any public comment if anybody has anything they want to bring up. Don't have much public here. All right. From Moss Adams, Tony, would you like to come up to the board?
He's bringing us money.
It's just a couple slides, so.
Don't knock over your pen. Yeah. There it is. I've got a new cable.
So since we're here doing the audit this week, I thought since there was a board meeting, it'd be a good opportunity just to say hello, do our quick entrance with the board, just reintroduce ourselves, and give you a slide overview of what we're doing as part of our audit this week. And I'm Tony Android, as I think the whole group knows, partner with Moss Adams. This is our third year doing the audit for Lake Health. Ashley Austin
I'm a senior manager with Moss Adams. I've been with Moss Adams for 10 years, and I've been on your account for 3 years now, too.
She's been on the on-site lead on the audit engagement, and then Paul Holden is our lead on the cost report side, so he'll be here for the final presentation. He actually went home last night for some of the meetings he had today, and tomorrow actually up in Seattle, so we're just going to go through, like I said, just a couple of the highlights that I wanted to make sure we talked to the board about. Just our required communication with the board requires that there's certain communications to those charged with governance, which is the board, that we communicate an overview of the plan, scope, and timings. That's what we're going to do tonight. Just have 2 slides talking about our timing and the audit process, etc. And anything else we think is relevant to the group.
So, as you know, we've been on site this week for field work. We leave tomorrow, and we'll leave a pretty extensive open items listing with management. And we may actually be back for a few days to kind of finish up our open items once they've been kind of completed by management. Delivery of the financial statements is in December, kind of to be determined by your board meeting, and then also when our audit is finished. Deliverables will deliver the audited financial statements. As you know, the only thing that's in those financial statements that are Moss Adams is the opinion, so we'll deliver the opinion. We'll deliver a report on Oregon minimum standards compliance, which as a government hospital, you're required to meet certain compliance standards with the Oregon minimum standards, so we'll look at that. We'll also deliver a letter to the board and then a letter to management about any sort of deficiencies that we found during our audit. And then in terms of the cost report completion, we try to get that finished by the end of November, but dependent upon the completion of the audit. So
Yeah, whether it's early in the month or later, it's due by the end of November. As you are aware, this is all for the June 30th, 2015 fiscal year. So Lakeview Gardens was spun off during the year. So this is all, when we're reporting to you, it's really to the district. There's now a separate entity, a separate audit that we're performing for Lakeview Gardens, which is actually considered to be a not-for-profit because it's all rolled up into Goose Lake Medical. So it's that's not-for-profit accounting versus governmental accounting. So, so when we talk to you, when those charged with governance, we're talking to you as a Lake Health board for the Lake Health financials versus the Lakeview Gardens. Sorry, I was going to say Goose Lake. Put myself off. So just to make sure that that's clear to the board, that we have that designation between the 2 entities and there's a line in between. We will report to you when we come back any weaknesses or deficiencies in the control processes. I can tell you right now, I know one of the concerns, especially with the first year of Lakeview Gardens, we'll probably have a comment in the letter about clear separation of Gardens versus Lake Health District, that the accounting is completely separated from the accounting for the hospital. So in the first year, there's still some accounts that are getting separated, broken apart, and I know Cheryl's having a good time with that, so we're gonna, that's part of the pieces that we'll be back to look at, to be sure that that's all been done. But we'll probably have a comment in that area just because that wasn't done during the fiscal year. Hopefully this year that continues to be separated and completely broken out from Lake Health District. From the accounting position, the reporting you're receiving, I understand, has separated the two, but the accounting, the trial balances are still commingling some of those accounts. So we want those pulled out as much as possible. And obviously we're going to finish looking at the allowance for accounts receivable, making sure that the amount on your books is the amount you're going to collect. So we're in process on that. I'm hoping we'll have final resolution tomorrow. If we, for some reason, don't agree, I'm hoping, it looks like we're going to probably come into agreement, but we'll have our final work tomorrow to make sure that that's all looks fine. As Ashley mentioned, there's some open items that we're going to leave tomorrow to work on, and so we're going to come back in a few weeks to hopefully wrap those items up once Cheryl had some time to look at those and provide us with what we need. So, and with all the activity of Lakeview Gardens separating and all that, I mean, it certainly has been a little bit more activity here from the perspective of accounting, having to separate all that and take care of that. So it's been, I think, a lot of work on their part, so we appreciate all the work they put in. We know it's probably not been the easiest audit this week just because of all that that's going on, so we appreciate everybody's hard work on that. Final slide I have is just making sure that we've talked to the board about fraud, any misappropriation of assets, financial reporting, whether it's at the financial statement level or it's any theft of assets, that sort of thing. So kind of our question to the board is just to ensure that if there's been any fraud, that you make sure to contact us. I don't know if that's something you can comment about at this moment, but we do want to make sure our lines are open communication-wise, that if you're aware of something, we want to hear about it. So we talk to different people throughout the organization about that issue. And if there's anything, we follow up on that. But we also want to make sure we've got the opportunity to ask the board that if you're aware of any, that we want to be contacted about it, if this isn't the right venue to discuss it. And
One quick question.
yeah.
How important is it to you to have dual signatures on the checks going out? I know the banks don't care.
The banks don't care and the banks don't look at it. When it's over a certain dollar threshold, it really depends on the internal controls. So if the internal controls are strong enough, then maybe you don't need the dual signature. If you're saying, no, it's a small shop, which Lake Health is, it's not a bad idea for large checks to have a dual signature.
What is it, you have a large check in your,
For this organization, it could be 10,000 or 50,000, depending on what the controls are. I'm thinking whether I would say 10,000 would be the right number for this organization, 10,000.
Okay.
But all the controls still have to be in place.
Right, I understand that the other controls have to be there, but, you know, when you're signing a $5 check, I just...
Right. And a lot of checks these days are electronic, so you're doing a lot of
Well,
EFTs.
payroll is electronic, so we can authorize payroll with a cover signature, but the accounts payable and everything when you're going through it, you got
Yes.
100 checks to write. Okay.
Generally, I mean, if the board or management feels differently that the amount's a little lower, that's certainly something you can do with my off-the-cuff comment in consultation with an expert.
With someone who knows.
I've looked at your check register, so I know that there's, you know, a larger distribution of checks that are over 10,000, and, you know, so I would think that that would be a good split of risk based on a review of your check register, but that's off the cuff.
No, that's fine.
All right.
With that, thank you very much.
Thank you.
thank you.
Thank you.
Look forward to the completed report.
Yeah.
Approval of consent agenda. Anybody got any questions about the minutes or anything? Look good to me. Can I have a motion?
So moved that the approval of the consent agenda items be approved as presented.
I'll second that.
Those in favor?
Aye.
Aye. Thank you. That's approved. I'm glad you're so excited, Joe.
I hardly hold back my enthusiasm.
Financial report, Cheryl.
I had it rolling and then it just drag and drop, and I just had it going, and now I can get it to go. So.
Well, you guys have all see the report, you want me to just start, and then she'll probably get
I
it,
want
because
to
we
know
are auditing her.
why receivables went up and cash went down.
Yeah, well, no, you're absolutely right.
Smirk on your
I mean,
face.
800,000.
800,000 between cash and receivables. Do you want me to address that first or later
Sure,
on when
fire
we get it? Okay. Balance sheet and revenue was normal, but cash went down 800,000. AR was up 800,000. We're struggling in the business office. We've been working really hard. The best thing I can tell you about that is in September we collected $1.9 million, so it starts to bounce back. In October we have already deposited $700,000 as of the 7th of October. So we seem to be collecting that money. Would you agree with that?
I agree.
So I hope that will keep up. I mean, if that keeps up in October, it's going to be a huge month for collections. So that's
So
back.
you expect this to be just a 1 month anomaly, it will be bouncing back
Well,
at the end of
a
next
couple. I
month?
mean, it sure seems like we
Maybe
had,
it'll take a couple months.
but it was a good collection month in September. So you had a couple $100,000 there. I don't know what the revenue for September yet, but I do know that the collections were over 1.9 million. So our average monthly collections last year were 1.7 million. We actually collected almost 1.7 million in August. So,
Now, the new clinic revenues are in this,
yes,
so it should be higher.
right, so we're starting to collect that. Yeah, and we certainly did have a pause and a struggle with that, bringing on the clinic and working out new processes. But honestly, I think we've resolved those issues crazy quick. I mean, I'm really pleased that it's going as well as it is. It could have been a lot worse as far as the length of time it took us to all get used to the new processes and getting things to work and getting information where it needed to be and getting the claims dropped. It could have taken a lot longer.
Yeah, we had to implement new software in the clinics, had some workflow pauses. I mean, we expected that.
They had never used CPSI before, so they're all using CPSI in the new clinic. They started it right away and they're doing really well.
So the charge entry was where it lagged. I mean, charge entry and the time it takes to send the bill out because of the learning curve. I think everything's starting to smooth out.
Okay, so here is our patient counts for July and August, and really I'm just focused on year-to-date mostly when I'm looking at this. Our hospital patients are up a little bit, so between prior year and current year, they're up a bit. Emergency department is actually down a little bit, not a whole lot, but a little, so that's interesting. Surgical patients year over year were up. Inpatient, we've got quite a few less surgical outpatients. So we'll see in this whole month that the surgical department was pretty slow in the month of August. We were kind of transitioning into our new surgeon. He wasn't really here, Bradbury wasn't here, and it's been a slow start. So this has, that has a big impact on our financials this month. The lab is really kind of steady. Radiology continues to be very busy. The rehab continues to be very strong and doesn't seem to be slowing down. Listening to their report every morning. Long-term care days, we've had a couple of kind of low census months. It seems like it's coming back a little bit. Home health, you can see that this year has been radically more busy than last year. But look, we've dropped in August almost by half again what we saw in July. So that's just one of those departments where it's really difficult to predict. It just is kind of random. So health clinic saw 800 patients. That's between the two clinics. We don't really have comparative data yet. We won't have that for a few months until we get to a point, we didn't open our clinic until like February, so this is maybe not gonna be a very useful number to us for a few months, but we'll get there as we build the data. The revenue for the month was up 6%. You know, it should have been up more based on our budget. Surgery was a slow department, but the clinics are doing pretty well as far as what we expected from them. And of course, it's still really early in the year to decide how, you know, whether or not this is going to be the trend we were expecting. Our days in AR went from 76 to 78, not surprisingly, because our cash is up and our AR is up and our cash is down. Also, looking at days cash on hand, that went down, and like I said earlier, I mean, we collected $1.7 million in August, it's over 1.9 in September, and October looks to be a big month. So our days cash went down a little bit, but I expect that's going to bounce back in the next few months too. So then our profit and loss for the month, current versus budget. We did have less revenue than we expected. A lot of that's related to surgical revenue, but our expenses are also quite a bit less than what we budgeted. In part, less surgery, less surgical department in the hospital, less anesthesia. So expenses anywhere are less because we don't have all the doctors we budgeted for yet. So we actually ended up with a net profit, an operating profit for the month of $2,000. And after non-operating revenue expense, we had a net profit of $152,000, which brings us to $210 for the year. So we're still at $193 ahead of what we budgeted. Questions? Based on what Tony said, we actually, so I've been presenting the Lakeview Garden financials to you, and I have separated it in our, I've removed those expenses from our books, but the thing is, we're still billing out of the CPSI billing system. So while Lakeview Gardens is separate and we're keeping track of it, it's not writing its own checks to pay its bills, and the billing is coming out of LHD's billing system. So that's what we've got to separate. And when we buy that point-click care, which, when do you think?
We have kickoff
Tomorrow, but when might the go-live be? That's only a few months away.
Yeah, we're November and December, aren't we going live, and they're doing relation servicing. We learn more of that tomorrow.
Okay.
With the kickoff,
So,
but that's the
but
anticipation.
it's a much quicker go-live than you would have like on other bigger, something like on CPSI. I'm sure we didn't have a 2-month, window there. So when we go with point-click care, that we'll do the billing out of that software, and we'll write checks out of that software, and we'll get the separation that they really want us to have.
Okay. As an example, we will have 20, 25 bills to send a month. You don't have to fill only so many patients given the transition and what changes. It's a much smaller environment to deal with. But it will help nursing an enormous amount, and it'll help in that separation that Tony talks about.
And we did know, we knew that this was kind of be an issue, but if we had bought a separate billing piece for Lakeview Gardens, the cost would have been over $60,000 to send out 25 bills a month. That's just crazy. So we knew this was coming, and but we are dealing with it. So we get. Okay, questions? Okay, so then for the balance sheet, you see that that we talked about. Our cash went from last month $1 million down to $270 here, the unrestricted cash, and our receivables went from 5 to 5.8. Otherwise, we kind of all steady and there's really nothing that's noteworthy. You know, that net difference is very small, month over month. Okay, so then we will talk about Goose Lake Medical and Lakeview Gardens a little bit. Lakeview Gardens, the P&L for the month is here. A primary reason for this loss was taxes, which where are they? I can't figure out where they're buried. So they had, their census was low, so their revenue was kind of low.
I don't see the taxes in there.
I think they're July. There they are. No, that's not where they are.
You got
They're
other
in
license
there.
and taxes, $232, doesn't look too bad.
Where are they? All right, well, I'll have to figure it out.
Well, how much did you have to pay? And it was,
It was $40,000.
see the year-to-date, in the 2015 year-to-date, you can see the 44,000. So this-
Oh, because it was July. Oh, I'm sorry, I was
Maybe in
looking-
September, I don't know, see this
Or
through
June,
August.
it was June's expense.
June, that you paid them, okay.
Yeah, it was June's expense. 'cause
So
it's
you
quarterly
won't
tax.
see it for
So I
another
lied. Yeah,
10 months.
sorry, it is there. Okay, anyway, we still lost $37,000. I guess that's the other thing I was gonna say is, yes, we are having some discussions about how to allocate these expenses, how we have to do it in such a way that we please Medicare, but we don't wanna overcharge Lakeview Gardens. We don't want it to lose money. So we have to charge a fair amount that's appropriate, but we also have to we have to have an entity that breaks even. So if we decide to change any of the expenses that I have allocated to Lakeview Gardens, we really won't change. It might be that some expense moves from one organization to the other, but the bottom line altogether is not gonna change between the two. Does that make sense?
Do we charge for the actual space?
We aren't really charging, I mean, we have like $1 rent, so we're not really charging for that space. But what we charge for billing and purchasing and maintenance guys and Charlie's time and my time, it's a gray area, so we have to be prepared to be able to prove our numbers to Medicare if they choose to audit us. We want to be very careful how we're going about this, and we also want to make sure we have good documentation from all of our departmental managers. So we have been in quite a learning curve with all of us of how to keep those records so that maintenance keeps track of the time that they spend in long-term care, and dietary tracks, the snacks and the extras and whatever that we spend down. So.
At the end of the year, if we have a loss, which I would almost expect, how do you fit that into the overall picture?
Well, as an entire unit, we know that Lake Health is getting better reimbursement because of that separation.
Right.
But we do have to find a way. It can't lose a lot of money on its own. I mean, we've got to find ways to, and really I would say a big part of the problem is the census has been low. It has been a little low, and when it gets back up to 2022, we do okay. We don't need to make a lot of money, but we do need to have a small profit down there. So we need to manage it to get there.
One of the issues that the auditors want to make sure that we work the balance correctly is if it does lose a lot of money, then it needs to be supported by the district. If that's the case, then it becomes, you have to consolidate both sets of organizations, which means that we would lose the benefit of having done the separation. that's why, you recall, when we worked very hard to keep Goose Lake separate from Lake Health District, so that we don't have it viewed as a consolidated financial statement. And that's the term for, when you take all the entities, put them all into one profit and loss and one balance sheet.
But the community tax base can't be a portion attributed to the long-term care.
No, because they're separate entities. Goose Lake is a nonprofit, separate organization, and the district is a taxing entity. So you cannot, and that's one of the things about the resolution, is that we can't take any tax dollars and use them for non-district purposes. So we want to make sure that we're doing this as carefully as we, and thoughtfully as we can. And we, that's what Moss Adams is helping us do.
Okay, so one of the things we have done, if I can interrupt a second, is one of the reasons we've had some people not want to come to us is because of lack of private rooms.
Right.
So I've taken, and we're consolidating, moving we have the dining room and the living room as underutilized areas. We are now making that also the activity area. And we're taking the current activity room in the solarium, and we're making that the classroom, which then opens up 2 more private rooms. So that we were going to have where the solarium is now as a classroom next year when we move to the new buildings, but instead of paying to put it in the old classrooms and then paying again to move it, because there's certain requirements we have to meet for the KCC RN program and where their stuff equipment goes. So instead of doing that 2 installations, we're only doing 1 and getting that done right now. So we have to put in storage area for all the activity supplies. So those are, I think the quote is on Charlie's desk now for cupboards to be put into the dining room, and then that move will happen. So that'll open up 2 more rooms we can make as private bedrooms.
Melinda, what's your sense about our census when we're in our new facility? Do you see, have you?
Well, assisted living will be full.
It will.
I think pretty darn
Really?
close. I've had people asking me all the time, or, you know, how soon is it going to be open? All the time.
How are we going to operate that? Is there something that, are we going to have people, are we going to have a waiting list? Are we going to have people sign up? I mean, how?
Well, I haven't addressed that yet. I do know from being involved with the Quail Run over at Quail Park or whatever it is over there in the falls. They did a waiting list, and then they'd open up so many rooms at this time. People that are already involved in the system get first choice. And so if I have a resident that's just hanging on here with us in long-term care right now that's truly appropriate for assisted living, they get first choice in the bedroom. So we'll do that first, and then we'll start reserving rooms in people's names, however we determine to do that. And I just not quite sure on that process yet.
What is your intuitive feeling about long-term care? Will our census grow with the new facility?
I'm hoping it will with private rooms. Private rooms is a big deal. You know, I thought we might be able to make it a little bit longer, but it's a big deal. I mean, I have people 2 or 3 times a week say, can you get my dad moved to a private room? I said, as soon as I have one available, I will. I mean, I just don't have them available. So, and I did here in the last month have 2 people say, you know, I'm glad Mom went into swing bed over on the hospital because she got her private room. And if we had to make the decision, I don't know that we would have brought her here if we couldn't be promised a private room here. So that is brought up with every conversation I have with the family. And we do have one of our residents thoroughly enjoying the coffee cart.
Really?
You betcha, she's down there about every other day buying her some coffee.
So what are we gonna do? We're gonna put coffee.
I don't know, we'll figure this out. But that's one thing I'm trying to do right now is to get some more prep rooms. So.
Going backwards, I forgot to say, we had our rural health clinic certification last week. They came, and we passed with flying colors. They were very impressed, and so it's really much work of Brian and Lisa Pike that made that happen, but they were really impressed, and they told us we did a great job, so now we're just waiting for Medicare to do their part, which can take a few weeks, so, before we can actually start billing as an REC. But we're very excited that we thought we had prepared well, we thought we were ready, but we're glad when it's over and you did a great job.
Are there additional things we have to do?
No, none, not a single deficiency.
We just need to wait for Medicare to issue the certification number.
And we'll begin the irritating process, irritating
Charlie's
them.
gonna do that.
I said,
Squeaky wheel.
could we start calling next week? And the inspector said, that would probably be the fastest turnaround I've ever seen. But you would try.
We also had a Medicaid or Medi-Cal inspection in Alturas at Goose Lake last week, and we passed, I think it was 97% passed that inspection.
Yeah.
Good. So you get 2 halos, not just one.
Yes.
And can we bill Medi-Cal from here?
We're in the process. We don't, we can bill them for emergency room, outpatient, so MRIs, labs, but we're not seeing their, like our CCO, we're not seeing the PHP patients, so the Medi-Cal, we're not seeing them for primary care. Yeah.
I think you need to understand that, so a Medi-Cal person who is in their, like our CCO, they call them an ACO, the name of that organization in Northern California is Partnership for Healthcare. So we call it partnership. They can come here for approved procedures or for approved MRI, CT, that kind of thing. But they can't come and go to see Dr. Gallagher or Dr. Hussey or Dr. Lee as their primary care physician.
So will that change?
What we have been working with them on is a contract so that we could take on more patients in our Alturas clinic and get the referrals for the specialty care here. And several of the specialists have said, I'd be interested. And so we have to get the right rates to encourage. So for example, there's a good one is orthopedics. It's hard to get partnership patients to be seen at, well, they have to drive to Redding right now within California because they don't have a contracted practitioner. And if we could get the rates that the orthopedists that we contract with are willing to accept those rates, and we're very close, and we could have that business here.
Goose Lake Medical Services, we went live with the clinical in the beginning of August, and you can see that we are having trouble with our billing. So I didn't have the month in here for some reason. So I didn't copy this slide very well, so I'm sorry, but the revenue for July was about $57,000, and the revenue that we reported for August so far is about $7,000. So So it's not that it's lost, it's just that we haven't been able to actually transmit those claims to the payers. We are actively working with IT and the doctors. The doctors are not happy with the situation, so we will get those bills out and we will get paid.
One of the doctors it's working out okay, the other doctor, there's a lot of challenges that she's willing to, I mean, she continues to improve, but it's a slow process. But the bottleneck is the clearinghouse. It's the insurance clearinghouse. So part of our claims are the doctor and the other part, the clearinghouse, the insurance companies we're having issues with. Those should be resolved shortly.
Shortly is 1 month, 2 months? Will we see an improvement here?
I'd say 2 months.
So we should have a month where we drop a whole lot of bills, and then we should get paid within 10 to 30 days of most of those bills. So, it's frustrating, but the other thing, I guess, because I'm always looking for the positive, what we have learned in Goose Lake is gonna make the transition to e-clinical up here in Lakeview much easier, because we have learned a lot. And so we hopefully will get all of our ducks in a row so that when we make that transition, there will not be this decline in revenue for our clinics up here, because that would be quite a bit more devastating. So, anyway, we're learning. I just thought of something, I lost it, something else that really good happened, but I can't remember what it is now.
I can't remember. Can you remind me, is this cash basis or is this accrual?
No, it's accrual.
So it's just simply having the bill?
Well, it's accrual. I should have accrued the revenue, but I felt like that's kind of, I mean, the revenue is there,
But you
but
got,
the bills haven't gone out the door.
that's when you
so-
accrue when you send the bill out.
Well, yeah, so, exactly, so. All right. Oh, I know, that's what I was gonna say. ICD-10, remember ICD-10 went into effect on October 1st, right? We've been hearing about it for years. I don't believe it has slowed us down much at all. So I'm very pleased that, that we're prepared and that we're getting our bills are going out just fine and there won't be a problem, because of that. So I think that's a wonderful thing. I haven't really heard about how the rest of the world is doing. Have you? I think
It's too early to
It
tell.
feels a little bit like the whole Y2K thing where we're all getting ready for a disaster and then nothing happened. Okay, so balance sheet, nothing, I shut up. That's the balance sheet. And there's really no change there except just our receivables are going way down, bills aren't going down. So is the cash, bills are going down. All right, questions on Goose Lake or anything else?
Item D.
Oh, yeah, we sent you all a copy of the commitment to adopt patient-friendly billing practices, and I think it's great that OAHHS is working with all the hospitals to be progressive as we can be and try to keep up, and that we are doing all of the things that they would like us to be doing, to be part of that group. So, and I wondered if you had any questions about that.
Okay, thank you. Charlie, we're going to talk about the case review grant.
Yes. ORHQN, which is the Oregon Rural Health Quality Network, that has actually started with some help from Oregon, so it's been involved for probably close to 10 years. It ceased to function as of September 30th. And largely because of multiple reasons, but some of the funding was going away for some of the programs. It was moving from an independent network to some of the bigger associations. One of the programs that the ORHQN sponsored was Team Steps, and that was a large chunk of money was given to a group and sponsored by one of the hospitals to continue Team Steps, which is a really good program, and we've been able to participate. Another of the good programs is the case review program. Case review is, since we're a perfect example of all the other small hospitals, a certain number of charts per year would be reviewed by any of our doctors' charts. But we're too small for one of the doctors to look at the other doctor. They're too close to friendship. So you send it to independently, send it to have somebody else review it who's in a similar situation. So a case of Dr. Graham's would be reviewed by another family practice physician in another critical access or small community. So it's a fair comparison. A surgical case reviewed by a surgical case, not someone who's in Portland or Salem, because that's unfair. How you practice is different. So to keep that program going, ORHQN provided us a grant of $75,000 so that we would maintain the program for at least 2 years, and gave us the rights to the software. So the program has, the way it works is you take a chart, and we've been either sending a copy of the physical chart to that reviewing physician. They do the review and they mail it back. We act as an independent agency and then mail it to the other hospital. Or we do it electronically, scan it, and put it into an encrypted format, email it to that, or send it to that physician, and then they review electronically. So Nam Dadi has taken on that responsibility, and we hired someone to help her. We have been doing this now for a couple of years, where we've had a part-time person providing that service, and we're just continuing that.
Does a physician get paid for the review?
Depends on the community. In some hospitals, it's part of their contractual arrangement with the hospital that they will review charts. In other cases, they pay the physician saying, here's X dollars to review this chart. So it varies. But it's a good program for us to continue, and we get to be a part of it.
Okay. Medical staff privileging, we got any
Dr. Graham was going to be here. He must have gotten called away. We had our meeting this afternoon. He thought he would be able to be here. We have, I don't know if did we send you the report?
I believe Cheryl is a wound specialist and not a wound specialist.
Oh, did I have a typo there? Sorry. Thank you. I was going
You're
too fast.
welcome.
The only ones they did not receive, Charlie, is the sleep lab ones for Providence.
Okay.
I do read those.
The sleep lab,
Thanks.
we have, as Lake Health District, we have an agreement with Providence Health Services that we accept the credentialing that they do as quality credentialing. They've done that for the stroke program, if you recall. We entered into an agreement with them that if they credential the stroke physicians, so the neurologists, neurosurgeons that provide the advice on our stroke computer, so it's sitting in the emergency room, the patient comes in, and that physician pops up and is available to consult our physicians. The credentialing has been done by Providence. The same thing holds true for the sleep study physicians, since they are provided by, on contract, by Providence physicians that are qualified physicians. We just accept their credential. It's not something that our medical staff or you would have to approve per se. So, at our meeting this afternoon, the medical staff agreed to all of these additions and renewals. I could read them if you like. It's the same list that you got. And so they recommend to you that you accept these, because they approved them this afternoon.
And there's one that we didn't get, did you say, Jay?
Those are the Providence Sleep Lab doctors, Dr. Michael LaFleur, Dr. Louis LeBay, and Dr. William Bauerfeind, who have been credentialed and approved by Providence Health System. Other than that, that's the same list.
All right, may we have a motion?
I'll move that we accept the medical staff privileging as presented.
I'll second that.
Those in favor?
Aye.
Aye. Thank you. Teresa, nursing report.
Well, it's been a very interesting month. We had that slow month followed by nothing but busyness since. We did have, I think one of our record swing bed sends us up like 8 patients for a while.
That's where my patients are.
Yeah, literally. At any rate, we have been suffering from an unusual amount of medical leaves within the staff. Some of our key people have been out, so we've all been working, including me, working nights and days and weekends and that sort of thing to keep going and then have the high census on top of it. So at any rate, we do have some new hires. I have 2 new grads working. One has just come off orientation, one is just going on. So that's good news because they both are doing well. And I've hired several CNAs. Unfortunately, I hired them from Lakeview Gardens. So
Well, it's only fair, you got the patients, you get the people.
well, that's a good point. Thank you for bringing that up. We did start the T system. We had our go live with that. We're struggling a little bit because, again, key people are out. One of them being Abby, who was our lead person on that project. So that's made it a little more challenging. But we're plugging away and it's moving forward. And then we are doing multiple classes, both for physicians and nurses. So we have that going on too. So I guess that's just my summary. Any questions for me? I didn't talk about infusion therapy, Brian, because I have a hard time articulating it. I don't know if you want to bring it up.
Sure.
Okay. Go ahead.
Okay. We are contracting with an infusion case management company. And this company is a specialist in getting approval, managing all infusions directly with the patient. And they work with our team and help market our infusion services. They did a study on how many infusions we're losing, and they're going to market to the outliers in our area. Charlie, what was the number that they, remember the number that we?
There's multiple different types of infusions and services, injections, different kinds of medication that we could be providing. And they are quite confident that they will be able to really help our community members that are driving unnecessarily, not knowing all the services they offer. Or they may not be knowing about all the medication that is available. So they gave us some projections. Sometimes projections are a little bit rosier than the actual, and sometimes they're significantly understated. But probably the most significant thing that I see is that aside from it making it much more workable for our staff so that we get patients, we don't miss as many times when patients either fail or don't get their authorizations. They show up, we haven't we haven't mixed the medication and the patient wasn't ready or the insurance wasn't ready. But the other part that I think is really going to be exciting is Many of these medications are very expensive, and they work with the drug companies to help find grants to help pay for the cost of that medication. So somebody may have insurance, but they may have a $5,000 copay, and the medication is $10,000. So that patient has to come up with that money, and the drug companies often have granting programs to assist. We don't have the staff to be able to find all those programs and to help those patients. And this company works very good at getting them. And hopefully that will be one of the best benefits.
It'll be a little bit of a challenge to change our current process. A lot of our patients are used to calling, coming up and saying, I'll be there at 4:30 or something for their injections for the chemotherapy, biotherapy patients. And then we're divided, which is not something the company loves, because we do our antibiotic infusions through our emergency room, and we do our chemo and bio in a separate area. So will be a little bit of a challenge to them, because they're not, I don't think, used to some of our processes, but we'll ultimately have good scheduling, good education of the people of what this thing that they're going to do is going to cost up front, because that's been something I think, unfortunately, they sometimes brought surprises, so.
Does our staff, your staff, ultimately, do they do the infusion? The company just organizes everything?
Yeah, that's exactly right. They organize and
Okay.
work with the insurance companies and use the right words and the right codes to get things smoothed out better.
But they don't bring someone in that does the...
No, we still deliver the
No,
service.
it's still us doing it.
Oh, okay.
The time it takes to coordinate an infusion, time to coordinate with the patient, the insurance company, and the authorizations take a lot of time. I think Elena's, she spent 10 hours setting one infusion up. So that's the thing that she's excited about. And it would cost a lot more for us to hire an infusion coordinator than to bring this company in and partner with them.
What is their fee?
There's some setup time, and then we give them a flat amount of agreement for each time they provide a service.
It's a percentage of what's collected, so it's not what's charged, it's what's collected. And I think it's comparable, I think it's 5 or 6% or something like that.
And this is done all over the phone, electronically, in some manner. This company
Yes.
is not on site at all?
No.
They will come out to market and they'll make periodic visits here to meet with our staff, but they're not doing the service. We're doing the service.
They're based out of Dallas. So
Oh,
the
where?
vast majority is telephone contact,
Okay.
vast majority.
And they can do the work quicker and not take our time.
All right, thank you, Teresa and Brian. Teresa, I want you to thank your staff that pulls through every time we need them. It's nice that we have a hospital like this.
Thank you.
Chuck, could I don't think, but Charlie, we're going to talk about the CNA thing. I thought Melinda should, as part of the nursing report, talk about
Okay.
that, because we're having CNA issues and she
Yeah,
can
and
elaborate
you're
on.
setting up a training program, right?
Yes.
I did get it approved by the State Board of Nursing, we got that in the middle of September. Right around the 1st of September, the nurse that I got trained to do help in that teaching process was in a motorcycle wreck and broke her leg. So she's still not back. To get it moving along, I completed the training course this last weekend online and got my certificate, my applications at the State Board to be the teacher, as well as I'm working with another one of my nurses. So we will be meeting tomorrow to set up actual dates of a training class. So, because I don't know when my nurse will be back, and we are desperate for nurses' aides right now, so.
Yes.
We want
Really
qualified
desperate.
staff, so that's what we're going to do.
Do you have good sourcing candidates?
I haven't advertised yet because I didn't have set dates. But right now, I probably have 8 names on my desk of people that want the class, and that's without advertising. So, I think we'll do fine. In fact, I may have so many candidates, we only take 8 at a time. I may do right after the first of the year, start another class. You know, it's because there's that many people interested. I have a little gal out of Silver Lake willing to come and stay down here and take the class, so.
How many hours does it take?
155 hours.
Wow.
And 55 hours is, no, not 55, sorry, 80 hours now is, used to be 75 and 75, so it's 150. 75 classroom, 75 clinical. Now they've upped it to 80 classroom lab hours. And for the classroom hours, we contracted a company that already has a teaching program, and it's all done online. The students, they can do it at their own pace, but there's a limitation. They will have set lab hours that they are required to come in and put in the time and do the practice with myself. And then once they've completed those total 80 hours, then they have 75 clinical hours. The problem is that when I am teaching, I am not available as DNS. That's one of the rules. So Mary Margaret Schultz will help me with that portion. She will be the acting DNS when I am teaching or doing that. That is very clear with the state. I can't commingle jobs. But I have a system now I think will work.
Excellent.
It's really important we get it because for the first time in probably 15 years, we're using travel CNAs.
Yeah.
That's how desperate we are.
On a queue.
And I've been looking and I can't find anybody for long-term care. I've had 2 candidates, one had an Oregon license, one did not, and both of them turned me down within 2 days of being here.
And if you recall, the problem that we had with KCC was we had the clinical person who unfortunately broke her leg. But we were going to have the classroom component from KCC, and that was going to be done synchronously through the classroom or physically here. And she had health issues too. So
Speaking of that, what are we with the nursing program?
KCC. Okay. The first, this portion of the classroom, or of the program, is they're calling it the bridge year, and it was only eligible to those women that got their, or students that got their LPN. And so they're taking that class. We have one student that is in that and is taking it right now. Then next year, it'll be available to all those that have met the pre-nursing qualifications. So those there's been students taking classes for the last couple of years and getting all their prerequisites. And that will start next fall for the, I believe it is next fall, isn't it? Or is it next spring? I think it's next fall.
I feel like it's next fall. Yes, it's next fall.
So, but the first part of what the state allowed KCC to do is have the transition year, so LPNs to RN. And then the next year, they could start in with the new, or those that have met all the qualifications to have the 2-year program.
So where are we in that financial obligation?
Well, we haven't paid much of anything for the last 2 years. And they have not yet come and asked for more money. They haven't asked for any, I think we've maybe paid less than $5,000 of the $75,000 per year commitment for 3 years. So
And the equipment that I was mentioning earlier about for the classroom, that was gotten, that's going to be put in with the grant that KCC got. To put the,
that was not part of our commitment.
no, that's through a grant, special grant they got from rural outreach, and so we're one of those that.
I would anticipate that once the program is accepting those people that have met the qualifications, not the LPN to RN program, that KCC will come back and say, well, we started, but could you now start paying?
Sure.
That would be my expectation.
But there is anyway, in my mind, the thought that there will be some people in the program that are coming to.
We still are guaranteed 4 students from Lake County to be in that program. So that hasn't changed.
I have a few CNAs that have been working on the prerequisite nursing prerequisites as we speak.
The synchronous piece is still not functioning as well as it could. Our student is traveling to Glenwood for classes.
The one that's in the bridge program.
So there's no, that connection with the ILC is not yet created.
Actually, it's my understanding that she's now taking the class through Skype, and it is,
Here, in the hospital, yeah.
No.
Oh,
they actually, my understanding as of yesterday was that they took a computer out of the computer lab at the ILC and set it aside just for her to take it there.
Okay, so that's a step forward,
So-
which is good.
There are also 2 local students that were accepted at OIT for our programs.
they started this
Yeah,
in
they're
September.
going good.
They didn't want, yeah, that was a great thing that they got accepted. So we're still going to be getting nurses,
We have 3 people that
3
are
people.
in programs right now.
so that's still a great thing. And they were LPNs.
No, the 2 at OIT are, we're CNAs.
Oh, okay.
And these
Got it
are
wrong.
Lakeview folks. We do seem to do best when we grow our own.
Mhm.
Yes.
I mean, we really do. We have
They
more
stay.
One
long-term
worked for
benefit
Teresa,
out of
one
it.
worked for me as CNAs. Very good.
All right, Linda, moving on, you can tell us about workers' comp.
Yeah, well, our workers' comp insurance renews every October 1st, but you'll be pleased to know, when I came years ago, our experience modification was 116%. And everybody has, if you've ever been in business and used workers' comp, it's based on how many accidents you have, and your experience modification goes up and takes the premium and multiplies it either up or down. Well, we are decreased ours this year. It's been decreasing for years, but we went from 94% of our premium to 81%. That's very good. And then the state has lowered, every employee is in a classification depending on their position, and it's all based on how many accidents happen in that occupation. The only one that did not decrease is dietary. So it's not just based on us, it's based around the state. But the interesting thing is, because we took a lot of gross payroll on when we took the physicians on. But because they don't have too many accidents, they hardly have any, that decreased, overall we've decreased 20% in our workers' comp premium, which is a really big deal, because I was very worried it might go up because we're taking on a lot of gross payroll. But so that was excellent news. And on top of that, we will get, based on the whole state, how SAFE does it. If everyone has done very well, we get a refund, a rebate back, and we're going to give $37,383 any day.
Great.
So that's good. And that's, I just want you to know, because that's a very costly tax, we call it a tax. It's really, you're paying for insurance to any employer, so it's huge to have that go down. The other thing I want to let you know, and I know you're all aware of it, but I'll make it public and official, that my last day of work in this facility will be April 1st next year. So I'm gonna retire. If Don doesn't kill me in taxes.
Just telling us a big joke, right?
Yeah, that's right. That's all I have.
Well, I hope you can find somebody to do half as well as you've done.
Oh, we will. Everybody's replaceable. We will.
We will miss you though, Linda. You've done a
You
good
will.
job.
I'll miss it. I've always loved my job, always. It's a wonderful facility and a wonderful place to work. I mean, that staff doesn't really, I think they do realize how fortunate they are. It's a great place to work.
How many years is that?
I have Alzheimer's. Almost 29
Wow.
by the time I retire. The big question was I just gonna stay in my little long-term care room and get me a
Just wait till the new building opens. We're gonna try assisted living first.
Yeah, I might wanna go to assisted living.
Depends on how naughty she is.
Oh. So what's Dan gonna do with you?
He has to keep working to keep me in the style to
There
which
you
I'm
go.
accustomed for a little while.
When will you advertise for the position?
Right away.
Oh, will you?
Because it's gonna take some,
You will need to work with someone for a
Yeah.
while.
so, soon. I hope we find somebody very good.
Well, thank you, Linda,
Yes.
for years
Yes.
of wonderful help around here.
It was fun. It went by fast. And somehow I got old.
You're preaching to the choir. Shirley, do we have an employee to recognize?
You know, we have such exceptional people here, and I think it's, you know, as it gets harder and harder, and I have tried to find all different kinds of people, it's not hard, it's just we have so many that are wonderful. With our challenges that we have had in the last month and a half, with people being out, people being stressed, especially in nursing, we've had some people that have really pulled together and have really made a difference for us. Clearly, it has been stressful for Teresa, for her not having some key people. One of the key people that has done an exceptional job is filled in on nights of all times. And not because it was that they didn't have anything else to do, but because they knew it was the right thing to do. Kathy Smith is our nurse who has been here for many years. She works in our ER. She's been covering on the floor. She teaches EMTs, all of our volunteers. She teaches that class. She does mock codes. She just really is an exceptional person. But what's really made a difference, and it's hard for staffing, has been she's been so helpful covering nights. And some of our people that have been out have been night people, and that's a hard shift to fill. Kathy Smith is our employee of the month.
Excellent.
Sorry.
Thank you. And we can move into your report.
You know, one of the things that's really wonderful is that everybody else tells all the stuff that I had on my list to talk about. So I'll be a little more brief than normal. You know, I've been told that I should talk faster or not quite go so long, but I'll just try to cover a couple of things. The October 21st is when I'll be going to Portland to sign all the actually the 20th, I'm not going to drive that morning because it's probably 10 in the morning, to sign all the documents, and it'll fund on the 22nd. I don't see any reason that that won't happen. You've heard all the rest of the documents, and it should be, I think we're moving along pretty well. We have a meeting with Town Hall on the 13th to talk about the construction project. Daryl Anderson has helped us, and there are lots of people who have been helping to get all of our applications correctly in, get that approved. We have a meeting with Detroit and Pinnacle. So Detroit's the construction company, Pinnacle the architects, on the 15th. What is anticipated is that probably within 5 weeks, we will have firm date, firm dollar amount for the construction project. So based on the preliminary drawings, we'll be meeting on Thursday to talk about what about this, how are we going to do that, does it one question, perfect example is, are we going to, is the geothermal gonna work? Is it gonna be radiant heat? Is it gonna be heat pumps? Is it, exactly how's that gonna work? We've got all sorts of things coming together on that. So, again, 5-6 weeks is what the.
Does that mean that the bids will be out in return, the
Yes.
subs?
Yes.
Okay.
So we should have firm information. In that process, we of course still have, we're expecting we will have the town approval to go through with this project. I don't think we will have any problems, but planning commission is still what it is. So we have to go through that. We also have the certificate of need. We are in the expedited review process, and we applied quite some time ago. We've given them our financial projections. Now we just need to make sure they get their $42,000 fee for the process. But that has to be received. We also are working on the Weinberg application. So we've submitted our, they call it a letter of intent. It was much more than that, but now we'll buff up that application. They have added an additional step, and that is to take our financials and given that to an independent accounting firm. Apparently Weinberg has made grants, and the organization has gone belly up. So they don't want to see that happen. Going through we've talked with the Weinberg staff to make sure we're getting the application correctly. It will not benefit us to get it in sooner than November, because we won't get a final decision until probably February or March. And that's just their process. They're changing some of their process. They really like the fact that we serve underserved and
Underserved elders,
underserved elders. So,
poverty level elders.
and since the preponderance of our patients that are in our long-term care meet those criteria, they're very, very interested in our program. So we're involved in that. Any questions about where we're at with?
Let me clarify a couple of things. The October 13th meeting is a town hall meeting just to discuss the strip of property for back to the town of Lakeview. November 9th will be the planning commission meeting regarding our application to dig dirt. And that will be on November 9th. I think that one is at 7:30 at night.
Right,
on the 9th,
that's correct.
November
The first one's at 4 o'clock.
4 o'clock in the afternoon.
If
Probably
you,
wouldn't hurt for a board member to sit in.
if you'd like to.
Either one or both would be.
4 o'clock on Tuesday, 7 o'clock on the 9th. We were going to give you a little more information as we got further.
And one thing, Charlie and I did have a phone conference call with the Weinberg to kind of give us pointers in how to fill out this the application. And they require a minimum of 60% Medicaid clients in our long-term care, and we exceed that. We're a little over 80%, right in that low 80% range. So we do exceed the requirements there.
What do we have to do to avoid the tax?
85%.
85%.
Okay, get out and recruit.
Well, it's recruiting, and we always run 3 to 5 private pays, and that is the other part, and that offsets that percentage, so. Yeah, but we've never hit the 85%.
Amongst the other surveys and audits that we've had, we had the state come in and look at our mammography service, and we were approved with glowing comments, no recommendations. They were very pleased. So that's another indication of the kind of service that we're offering. We've hired a couple new people. Stephen Vance is our new IT manager. He started about 3 weeks ago.
He said 19 and a half days ago. Team steps.
19 and a half.
That's what he announced at Team Steps today.
What was unfortunate for him, his first day of starting, one of our servers went down. So was a little bit exciting on a first day, but he's, we're very happy to have him here. We've also hired a CHIP coordinator. Her name is Mira Norris. She is her Master's of Public Health and will be starting at the end of the month. So that will be replacing John Adams. JPIA meeting, the next board meeting will be next Wednesday in Alturas. And there continues to be a push to have us do something. We've been, actually a couple of hospitals have sent us the money to pay for the legal fees. So that's moving forward. And we'll talk more about that. Judy, I don't know if you want to comment. The last meeting we had was in August. So that's all I have.
But the JPIA hasn't set a list of projects.
No. We have several options that we're trying to do. And we have been pricing different strategies. One of, for example, is should we do something that we've already done and we will continue to do, and that is to have a charge master review. The other hospitals have not done that. So if we do that together, we could get a better price. We've looked at getting market analysis studies. So we've used a couple firms. I don't know why they struggle so much. I have a lot of information about our market analysis. And I think I sent you the Flex report that talked a little bit about how much of the patients within our zip codes. Did you see that report? Maybe I, okay, I'd be happy to send that to you. I have comparable informations for the other hospitals. And as we learn and grow sharing information, it helps us to understand the kinds of care that we're delivering. So we have talked about other different kinds of sharing, but we haven't come to a set agreement yet. We also have, hopefully, if we have enough candidates, we'll be able to choose the fifth board member. That's independent.
Thank you.
Did our candidate get submitted in August?
The other groups had not
Had not.
advertised like we
I understand
had, so we held back with.
Okay.
and
I
we'll bring-
understand there is another candidate being submitted,
Excellent, excellent.
as well as our candidate.
Okay, well, when we get that, we'll get that. So that's great.
Okay, anybody have any other questions? If not, we will take the 10-minute recess and we'll be back here about 8 minutes after, and we'll go into executive session under ORS 192.6,